A very good morning to everyone. This is Batu, the moderator from IGCP, and for today's session, I'll be the moderator here. I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who's present here with us. Well, it's on its introduction at our platform, but yet it's our great pleasure and honor to introduce him. He is none other than the very renowned endocrinologist, Dr. Anirban Sinha. Sir is MD in DM in Endocrinology at PCE, Associate Professor at the Department of Endocrinology at Medical College, Kolkata. Sir is Visiting Consultant at Amrin Hospital, Chairman Ethics Committee at Central Hospital, and CR Program Chair at Medicine Endocrinology at Medical College, Kolkata. With such wonderful insights, we will talk about the topic for today, which is management and diagnosis of thyrotoxicosis. Before moving on to today's session, let us have a brief look on what the topic says. So, as we have a very renowned endocrinologist with us, we'll be talking about the topic for today. We'll be also talking about as how we are supposed to undergo the treatment management and the treatment policy of this particular problem. So now, without any further delay, I would like to welcome Sir at the forum and like to hand over the session to him for his special talk to begin. So over to you.
Thank you. Thank you for your nice introduction. Without much delay, I'm going to start the talk right now. That is on thyrotoxicosis, and to start with, these are the trying to things we'll do. Identify the thyrotoxicosis from the clinics, that is history and examination. Choose the treatment. Then, depending on medical, it can side effects and what are the things which is required for control, and looking for complications like Graves or vetopathy associated, though it's a very big chapter personal. So I will just touch upon the situations. History, like most of the patients actually present to us with unexplained weight loss. Important cause of unexplained weight loss is maybe still now is malignancy, then maybe the metabolic disease like diabetes, and the hypermetabolic state like thyrotoxicosis. So if the patient has unexplained weight loss, we need to consider this and many other issues as well. So as there is the increased appetite is a clue that it can be a potential response of the thyrotoxicosis or hyperthyroidism. Unfortunately, many of the classic symptoms. No symptoms at all. Apathetic thyrotoxicosis is the term. Just a mild palpitation with the presentation, including with age. More patients have more overt symptoms, and elderly patient, as I said, the metabolically they get which is with the age. Response is slow or maybe some difficult to pick up. Artificially, poor itching of the thyroid or split the Graves. Phenomenally, we can find and be the patient present with itching all over the body. The concerns with the population at risk, the most on the psychosis or hyperthyroidism is smokers, family history of autoimmune diabetes, infectious anemia or history of diabetes. They have treatment like interference into the immunomodulators. They actually increase the risk of cytopenias. Patient history of radiation may be the cancer or maybe the other reasons. It's radiation. Thyrotoxicosis in these patients. First, it damaged or destroyed. The hypothyroidism, it can be thyrotoxicosis. Usually, the patient initially the features of acute thyroiditis like thyroid, but classic is resolved if it is proper, like that is which we nodular goiter patients are usually or but that 50 of toxic nodule in the thyroid, and the patient has more indolent course and more gradual and less symptom. can be occurs in postpartum people, postpartum silent thyroiditis, two of them, that is anything treatment, treatment also there is thyroiditis. Also, we can see the patient is know what cholesterol, there is a hypercholesterol, and the value of the prevalent ferritin is all things are really increased, and the functions as well beyond the thyroid levels. And the patient is the thyrotoxicosis. Uh, Most of the important causes of the elevated T4 levels, which are classically found in thyrosis, is classic thyrotoxicosis that we are dealing. Causes we need TBGs, as we have said, excess estrogen, hepatitis, HIV, drugs like methadone, even the fibrates, familial dysalbuminuric hyperthyroxemia, even the increased transthyretin binding like pancreas, hepatomas, drug like propan, anti-T4 level, things, and potential risk of elevated T4 with classical thyroidosis. So before killing the patient, after doses, we discuss along with the patient. T4 toxicosis is maybe the iodine-induced hyperthyroidism when the patient is on excess thyroid. Only the T4 levels are excess, but the free thyroid hormone, that is the T is not elevated. And T3 toxicosis is a presentation of early stage disease or maybe the autonomous thyroid nodules. So serum TSH level in these patients are usually less than 0.1. Subclinical thyrotoxicosis, which is lesser than that serious event, that is TSH level 0.4. So TSH level 0.4 we need to be careful about. But we should also remember other causes of suppressed TSH is acute non-thyroid central hypothyroidism. Uh, these are because of TSH without thyroidosis. So TSH before TSH is high, that is toxicosis. T3 toxicosis 54 may be normal, but TSH is low. When the T3 is only elevated, it could have been T3 toxicosis, it could have been acute non-thyroid illness, could be subclinical thyrotoxicosis, and as I said, hypertension, committed, I mean, you can present like this. You need to remember that because not always all patients are classical or may not be easily documented. TSH is normal or high. FT4 is also high. That can be because of TSH resistance, TSH secreting adenoma, hyperthyroxine when the binding of the T4 levels is high. TSH is also high. T4 is high, but it is not fun. So all should be kept in mind. Maybe this is one of the important factors when we ratio the T3 by T4 is done. It is more suggestive of Graves' disease. It is less than 15 suggestive of diabetes or other causes of thyroiditis or exogenous T4 injections. And find out. This is very important when you look for the thyroidosis to find out whether it is a cause or other cause. It defines like combination of antithyroid as well. In the pregnancy, the neonatal neuropathy, critically euthyroid patients also. So when the thyroid levels only disease antibody receptor antibodies the toxicity is very high. Orbital is very high. Unusual cases, disease, as I said, these are other things are very difficult to look for. In that situation, it is possible find out by the T cell receptor antibody. Other important diagnostic markers include ESR CRP, which is elevated in the thyroiditis, inflammatory effects of thyroiditis are also increased in the thyrotoxicosis, and the ratio some infections is very common, so we do it regularly. Another very thing that thyrotoxicosis is radioactive uptake scan. It the disease mentioned quite understand the key uptake situation is a homogeneous spectrum not uptake. So all these things are there with the different outcomes, and each mole or the choriocarcinoma, metastatic thyroid carcinoma, these uptakes can also be reduced by the stimulation. It is uptake with the thyrotoxicosis is or this inflammatory thyroiditis where the thyroid is actually destroyed. Uptake is low, but the thyrotoxicosis is there, and even the stroma ovary thyrotoxicosis, iodine thyrotoxicosis at the low upgrade features that the patient is not having the that is an important item in our hand. Hypothesis also. I think yes, we can also go for peripheral research test, but not commonly done, so I'm not going in details. What are the treatment modalities? We have surgery for particular modality, maybe the patients with high emissions, better to go for antibiotics because we can recover mostly after 2 years. The patient stops the treatment and resolves spontaneously, mostly on its own, and the antithyroidics also immunogenic capacity. Like we should with the mind disease receptor of TSH receptor antibody. These patients are favored for response. The patients with increasing surgery is with limited survival when the surgery is some or the antithyroid patients with unable to follow the radiation therapy because up to be getting pregnant or something when the radiation is contracted previously, but can make patient re-medication not possible, or maybe the operation just areas is not possible. We left with the option of other drugs. Again, there is a surgery option is absent, and the patients with use of because radiation can aggravate vitopathy, and we have to go for antithyroid drugs for remission initially, and we can go for or the vitopathy goes low. Patient planning for pregnancy 4 to 6 months therapy is possible, but after, otherwise it is not recommended. Individual with previous and patient with the surgical risk contraindicated for the antithyroid drugs. The hepatitis develops in the antithyroid drugs or agranulocytosis develops in the antibiotic is the only option. Surgery is important when the patient has huge the tissue, the tubes, as I said, more than 80 grams provided work well, like non-functioning nodules, or maybe the coexistence family planning and pregnancy is less important with the high TH receptor antibody titer because it can as well with you contraindication surgery can be planned for these. Now coming to the specific contraindication like restriction, like agranulocytosis, hepatic injuries, and the contraindication radiation is a pregnancy history, thyroid cancer, because thyroid cancer, the radiation is given with the diagnosis. It can change the tissue character, make it difficult to diagnose later. Again, surgery is for the severe vascular incompetence, surgical fitness, disorder, even in the pregnancy, after pregnancy, it is complicated because increased risk of preterm labor. I'm not going in details, maybe to the use of, and because radiation therapy again, before that we need antithyroid drug therapy to normalize the risk, may be used for high risk thyrotoxic symptoms, poorly controlled correction of the other like atrial fibrillation, heart failure, renal failure need to be corrected. Most of the 10 millicurie is hypothyroidism in 70% by 1 year. 15 millicurie 75% by 1 year. We commonly use and evidence that you go ahead just 150 even. So give 10 to 15 microgram and not per week or higher dose because they are more resistant to 20, 25 days required. Of hyperthyroidism occurs 55% within 3 months. So usually start falling after 1.5 to 2 months time and gradually up titrating the dose of the antithyroid drugs. Later, we may withdraw the dose or maybe requiring thyroid replacement. Development of the subclinical hyperthyroidism occurs around 3% in 1 year and 64% in 24 years. So we need to be vigilant on the post-radioiodine therapy. Coming to the adenomas, there are 75% patients who no longer hyperthyroid at this 3 months, so it is better response. Nodular volume decreased by 35%. If there is a compression that improves, risk of clinical or subclinical hyperthyroidism is around 8% in 1 year and around 60% in 20 years. So it need to be vigilant in the long term as well, post-radioiodine therapies. There is a long-term increase in some data, but mostly it is safe and effective. And there are modest fall in the testosterone LH ratio after radiation therapy that is subclinical and that is reversible. Radiation safety precaution, as we all know, avoid contact with distance should be maintained. Arrangement for the for commercial airplane possible to remember and explain to the patient. Antibiotics commonly used methylprednisolone 10 milligram is almost equivalent to 6 milligram of method. 10 milligram is equivalent to 6 milligram method. And change the one drug to other. Remember that the first pregnancy, Mr. Pregnancy does not cause significant harm. If the patient accidentally continues, it does not affect your outcome mostly. It need to be discussed with the patient. Baseline complete blood count are preferably done because these are altered by the antithyroid drugs. Mostly start with a single daily dose, start with the 10 to 20 milligram in the most of the time. If the PTV is used, 50 to 150 milligram 3 times daily used. But remember, previously, a lot of people used to go for block replacement, that is giving the high dose of antithyroid drugs along with the thyroid replacement like thyroxine. That is no longer recommended nowadays because higher incidences of side effect of the antithyroid drugs. Adrenocytosis, though rare, is a serious concern, more common with the PTUs. Again, fulminant hepatic necrosis, cholestatic hepatotoxicity, arthropathy, lupus-like syndromes can occur, both the antithyroid drugs and kept in mind, and patient explained about the symptoms, and patient need to be come up with the patient develops the symptoms. ANCA positive small vessel vasculitis can also occur due to plastitis, and rare form of methylmalonic atresia has been documented. These are very rare. When not to use, when the neutrophil count is then P2 and reactive, so other measures as we have discussed. What are the danger sites patient need to be explained, like fever, fatigue, pharyngitis, pruritic rashes, jaundice, alcoholic stool or dark urine. Monitoring is done usually after 4 weeks initially, then after 4 to 8 weeks, and after 2 to 3 months afterwards. And PTU induced hepatotoxicity, methimazole can be replaced to control the thyrotoxicosis that does not accept as the PTU does. Differential count could be done between when the patient has been for more than 5 days. The scopic immunocytosis should be kept in mind. Hepatic dysfunction, at least weekly monitoring LFT, if not resolution is evident, change the drug or maybe doing for other measures. Minor cutaneous reaction, maybe antihistaminic can be used, but if it is high, they need to be stopped. Large goiter is a very important predictor for the drug resistance, or maybe requiring longer duration of drugs, may not respond to drug, high level of TH receptor antibodies, and high color Doppler shows the high vascularity, also risk of cancer. Usually, as I have said, the muscle treatment is done for 2 months on average, up to 2 years. As I said, patient continued to be in remission usually after that. Remission rate not improved by therapy more than 18 months, but some patient prefer we can continue it. Otherwise, we need to look for the other measures available. Prior TSC receptor antibody may be estimated before predicting the stopping therapy to predict the remission, because lower TSC receptor antibody risk of remission is high. But improvement of remission is much higher with the levels of antibodies are low. Third function to be continued after 3 months, after 12 months after remission. I'm not going in details of the children, but methimazole may be the first line management. Initially 1 to 2 years, remission rate is around 20 to 30%. It is much lesser. Radioiodine avoided in the children less than 5 years, and the children given radioiodine less than 10 years of age. Total administration dose should be less than 10 millicurie, and beta blocker should be used if the heart rate is more than the children. These are the doses, titration, and again, the counts are important. Thyroid gland is again important. Serum antibody levels and the free T4 level is very high. There is a risk of remission is less. And again, just a few words on surgery, and I will stop my talk today. And patient who rendered euthyroid surgery, otherwise it is a risk. Patient require adequate beta blocker, potassium iodide required, usually given SSKI or Lugal 5 to 7 drops 3 times daily. And total thyroidectomy is a better chance, 0% recurrence, and near total has 8% recurrence rate. We mostly go for near total to total depending on the surgeon competence. And complication should be kept in mind when the patient is surgeon is left for hypocalcemia. The parathyroid is damaged, recurrent laryngeal palsy, postoperative bleeding, and mortality is low, but still should be kept in mind. I'm not going in the subclinical thyrotoxicosis, but did definitely exist. Other causes of the suppressing TSH with normal T4 and T3 need to be excluded, like steroid therapy, central hypothyroidism, and thyroid less in the critical care situation should be kept in mind when we treat the patients of subclinical thyrotoxicosis. There's also required treatment sometimes, and because of the cardiovascular events, I'm not going in details. End my talk here. Thank you very much. Any question is welcome.
Thank you so much, sir. Thank you for your overview talk that you have shared on our platform and for making our viewers understand about the topic in such a better manner. Moving ahead with the question answers round that we have received from our viewers. So the first question is related to the strategies.
Hello.
So hello, sir, am I audible? Hello?
Yeah, now you're audible.
Yeah. So as I was talking about the questions
Yeah, I can hear you.
That we have received from the viewers. So the first question is related to the strategies. So what strategies should be employed to monitor patients after treatment for thyrotoxicosis, and how frequently should thyroid function tests be repeated?
I think I have answered the question in my slides. As I said, it is depend on the it depends on the situation. If the antithyroid drugs are given initially after 4 weeks, then gradually every 3 to 6 weeks after, then gradually after 2 months, we need to check it. But important is to continue checking it. Otherwise, patient may end up in other dosing or excess dosing, end up in hypothyroidism in the long run. Many patients we have seen who stopped coming up, following up, and then ultimately patient came up with TSH of 34, become hypothyroid without treatment sessions. That should be kept in mind and explained to the patient that you need a good follow-up for the patients.
Thank you so much, sir. Thank you for answering that question. Moving ahead with another question that we have received, and the question is related to the major complications. So what are the major complications of antithyroid drugs, and how should they be monitored?
I think again, I maintain the detailed discussion in the slide itself. I just want names, to explain the names. That is agranulocytosis, blood count goes low. That should be kept in mind. Patient becomes fever, cough and cold for more than 2 to 5 days. Need to go for a blood count. LFT can be done. maybe if the patient becomes alcoholic, the patient LFT need to be monitored at least initially 2 months with antithyroid.
Thank you so much.
There, I need the slides, so I'm talking again.
Thank you so much, sir. Thank you for answering this question. Moving ahead with another question, the last question before we conclude. So, what is the role of beta blockers? What is the role of beta blockers in managing symptomatic thyrotoxicosis, and how should their use be balanced with their underlying causes?
Can you repeat the question again?
Yes, sure. So the question is related to the role of beta blockers. What is the role of beta blockers in managing symptomatic thyrotoxicosis, and how should their use be balanced with the underlying causes?
Beta blockers important because thyrotoxicosis causes tachycardia, and we require a lot of huge dose of beta blocker. Usually, propranolol is used, but any beta blocker can be used. Non-selective beta blockers are preferred. As I said, propranolol is preferred, but any beta blocker may propranolol up to 80, 120 milligrams is very commonly used, depending on the patient's pulse rate and patient symptoms. And after the treatment, when the patient thyroid levels are normal, we gradually down titrate them and sometimes withdraw them gradually. So depends on the patient's response and the thyroid because antithyroid takes some time to respond, and the helps you to get a better symptomatic control. So you need at least 40 milligram.
Thank you so much, sir. Thank you for being here at our platform and for sharing some valuable insights. I think that due to some network connectivity issues, sir has logged out. So not a problem. We will be concluding the session here for today. Until next time, and I would request all our viewers to stay tuned with us for the further upcoming episodes. Thank you so much, everyone.